Welcome to Module 2. This presentation will discuss the body's immune system. It's very important to have a good understanding of how this immune system works and have a basic understanding. As we go throughout Nursing 150, we will go over some disease processes that are as a result of a malfunctioning immune system. The immune system can become hyperactive and go overboard in its response, or it can be underactive and not protect us enough. So we'll just talk in this presentation a little bit how the immune system was designed to work normally. So our body is extremely unique in the fact that it has this immune system. If you really review it and study the immune system, it's very fascinating. We have such a cool mechanism in this immune system that protects us. So there's all these microorganisms and all this bacteria, all this crazy stuff floating around in our environment. But our body has the ability to fight this off, to recognize it as foreign, to recognize it as something that's not good for us, and it can fight it off. So it's really, and it does all this without us even knowing that it's going on. So very, very cool body system, and really is one of the most important body systems that we have, this immune system. So a lot of the disease processes that we talk about in this chapter, in this module, and in a lot of the modules down the road, is talking about disease processes that occur because the immune system is over-functioning, or it's functioning at inappropriate times, or it's under-functioning. So it's, like I said, it's really good to understand this body system, to understand those disease processes. We do, like I said, we have this mechanism in place to protect us. The soldiers, if you will, is what we call them, and those are the white blood cells. Many different kinds. If you can kind of pull back from maybe an anatomy class or a biology class, you'll remember that there's a lot of white blood cells, and underneath the umbrella term of white blood cells are very differentiated or specialized white blood cells that do certain jobs. They all kind of work together to fight off certain bacteria, and together they work to protect us. And I've listed some here on the slide. The T and the B lymphocytes are the ones that we will focus on for HIV when we talk about it. And then you have your neutrophils, macrophages, monocytes, eosinophils, and basophils. And just remember, I'm not sure if you've had this yet as far as a complete blood count as a lab value. Your complete blood count includes a white blood cell count. When someone asks for a CBC with a differential, what they're asking is that they take the white blood cells and they differentiate them. Okay, so maybe you have 12,000 white blood cells. Let's break that down and see how many of them are neutrophils, how many are macrophages, how many are monocytes, how many are eosinophils, and how many are basophils. The reason that a provider might do that is because they can kind of tell, it gives them a picture of maybe exactly what is the problem in the patient. If their white blood cells are elevated, they want to know maybe which one of these is most elevated. If you look on page 305 in IGGI, it's table 19.1, it differentiates all the white blood cells and kind of tells you what they are in charge of. So, for instance, if your eosinophils are elevated more than the others, then it's typically due to some kind of allergic reaction. So that tells the provider that there's some kind of an allergy or inflammation going on in that patient. I like to think of our immune system as an army. Not necessarily an army. Actually, they are the special forces, all of them, collectively. We have special forces like the white blood cells. And then within the white blood cells, we have even more specialized forces. That's our army that fights for us to keep us healthy. Each little soldier has its own job in the defense mechanism, much like our armed forces that protect our country. The mechanism that we have as far as cellular is white blood cells that have very differentiated different types of cells underneath the umbrella term of white blood cells. Those are your T lymphocytes, your B lymphocytes, neutrophils, macrophages, monocytes, eosinophil, and basophils. If you ever hear a provider say that they want a complete blood count with a differential, that's what it will provide for you. It will tell you what the white blood cell count is collectively, and then it will differentiate it out into the specific types of white blood cells that are present. The reason they do that is because as you'll learn, each white blood cell has its own specific job, and so if one's elevated as opposed to another, it can help us determine the cause of the infection or the cause of the rise in the white blood cell count. Some of these things that we can determine by doing a differential is we can determine the patient's risk for infection, the presence or absence of infection, whether there is presence or absence of an allergic reaction, or if the bacteria is actually a bacterial or a viral infection. The white blood cells provide protection through defensive actions such as recognition of self versus non-self. Self-tolerance is a special ability of the white blood cells to recognize healthy cells using proteins and cell membranes. White blood cells are the only body cells able to recognize non-self cells and attack them. One example of membrane proteins that provide self-identification is the human leukocyte antigen found on the surface of most body cells. Human leukocyte antigens are inherited and determine tissue type. Other defensive actions by the white blood cells, they can do destruction of foreign invaders, production of antibodies directed against invaders, production of cytokines that stimulate white blood cell production in the bone marrow and increase specific leukocyte activity. So these white blood cells are working hard every day to protect us, and it's pretty amazing that all this goes on and we don't even know it. They're just doing their thing, keeping us safe. I like to think of the immune system as our armed forces. It protects our body just as the armed forces can protect the United States for us. And within the armed forces, you know that we have specialized forces. We have the Army, the Navy, the Marines, and so we have different little specialized divisions of our armed forces as well that play a role in protecting us. Quickly, I'm going to mention the white blood cells. As you can see here, what is listed over here is the differential types of white blood cells. So these guys are all under the umbrella of white blood cells. So collectively, we have a number of white blood cells, and if you look at the number of white blood cells, you can then differentiate that number into, okay, how many of the white blood cells are T lymphocytes, how many are B lymphocytes, how many are neutrophils, and so on. So these are all types of white blood cells, and they're specialized. Again, they're kind of even further specialized special forces that we have. Each one has its own little job, and we'll talk about that as we go throughout this presentation. But one thing I do want to say is if you ever hear a provider or another nurse say that they want a CBC, which is a complete blood count with a differential, that's what they mean. They want to say, okay, there's 1,500 white blood cells, but differentiate them out to me. How many eosinophils make up that 15,000? How many neutrophils make up that 15,000? Because it actually can give us an idea of exactly what's going on within the body. A differential can be used to determine the patient's risk for infection, a presence of infection, presence of an allergic reaction, or possibly whether the infection is bacterial or viral. And we'll talk about that in the next few slides on how that occurs. White blood cells have the ability to recognize self versus non-self. Self-tolerance is a special ability of the white blood cells. It helps them recognize healthy self cells using proteins in the cell membranes. So that's how they recognize it. White blood cells are the only body cells able to recognize self versus non-self and to attack them if it's non-self cells. They can recognize on the membrane proteins. That's how the identification is. They're able to identify it, and this is kind of what's depicted here is like it has like a barcode on the cell membrane, and that's how the white blood cells determine whether it's self versus non-self. One thing that it helps in self-identification is something called a human leukocyte antigen. Antigen is what we have to kind of recognizes if it's a human antigen or a invading antigen. And the white blood cells have the ability to build up antibodies to fight the antigens, and we'll talk about that further on. This is just a good picture of the origin of all of our blood cells, red blood cells, white blood cells, platelets. They are all created in the bone marrow. The bone marrow makes stem cells. Those are like what I call baby cells. They're all little babies. And as they grow and mature, they, just as most of us do, we kind of mature and kind of go our own way. So basically, the red blood cells will become red blood cells basically based on what they come in contact with as they mature. And again, it's kind of like that specialized thing. They all start out the same, and then they get specialized. The reason I bring this slide into this is it's important to understand where our cells come from, because if you have an abnormal level of some of the cells, it could be due to a bone marrow disorder. Having a immune system that is working properly, the term is called Amino Competence. If all of our special forces are working like they should, we are deemed to be immunocompetent. But to be immunocompetent, it means that all the special forces are working. So we need the inflammation, the antibody-mediated immunity, and cell-mediated immunity to all be functioning as they were meant to be. And again, just to kind of reiterate, full immunity requires that all of these are working well and together. And we'll talk about these separately as the slides go on. So the first piece of this is inflammation. Inflammation is actually a good thing. The tissue response to inflammation is actually helpful. If it is confined to the area of invasion or infection, it doesn't extend beyond that acute phase. Chronic inflammation can cause damage and reduce function. So, inflammation does not necessarily mean infection. If there is an infection, there's typically inflammation there. That's because that is our mechanism. That's our first mechanism. That's our first boys going in. That's our what is that called? The Navy SEALs or the airborne guys that go in. That's the first line. Inflammation is. It goes in, and I have a picture coming up that kind of depicts on the process of inflammation. So this is the process of inflammation. It kind of goes through how when the bacteria enters, then our body sends platelets to clot. And then we have some mast cells that bring in blood flow to the area to bring oxygen to it. We know that things heal better if there's a good blood flow to it. And then the neutrophils, remember that's a type of white blood cell, and actually neutrophils are the most numerous of white blood cells that we have. And they are the ones that are typically elevated in an acute phase of a illness. The neutrophils start coming in and start killing things. Neutrophils and then the macrophages clean things up. And all of this causes an immune response. We want this to happen. It will continue until that foreign material is eliminated. Hopefully it's an acute thing. We get some redness. It's all related. The redness is caused by all of this happening. We want it to happen. It's a protective mechanism. And if this isn't functioning properly, we're going to get an infection related to this invasion. So, but like I said, we only want it to occur in an acute phase and not to continue on to a chronic phase. Okay, inflammation is also called our natural or innate native immunity. It provides immediate protection against the effects of tissue injury. It's characterized by blood vessel and tissue reactions to rid the body of harmful microorganisms. Some examples of inflammation without infection are such as sprained ankles. Myocardial infarction is actually as a result of some inflammation. Blister formation, thrombophlebitis is an inflammation without infection. Inflammation is also present like in allergic rhinitis, contact dermatitis, and other allergic reactions. Those also can cause some inflammation without infection. And then your inflammation caused by an infection could be appendicitis, pneumonia, things like that. 4 types of white blood cells that are involved in inflammation are your neutrophils, like we saw in the last slide, macrophages as well, eosinophils, and basophils. So those 4 are typically the ones that play a part in inflammation. So you can see as if we look at a differential white blood cell count of these 4 are elevated, we can say it's an inflammatory process going on for sure. 5 cardinal manifestations of inflammation are listed here, and we sort of talked about that: the warmth, the redness, the swelling, pain, decreased function, and hopefully that's an acute thing. It doesn't hang out in the acute thing. Consequences, if inflammatory responses are prolonged or occur at inappropriate times or inappropriate places, they can cause tissue damage and extensive scarring or loss of healthy tissue function. That's what we're going to talk about as we go through lupus. It is an autoimmune where the immune system is not functioning properly and it causes an abnormal inflammatory response. When inflammation occurs in response to invasion by infectious microorganisms, its action is to eliminate or destroy the invaders and prevent the person from becoming ill. So that's the whole reason that we have inflammation. And inflammation is needed to trigger both the antibody-mediated and the cell-mediated inflammatory or immune response. So we need all 3 of them together. This slide just kind of reiterates what I said before. Infection typically is a response to tissue injury, invasion of organisms. It's usually accompanied by inflammation, but inflammation does not always mean infection. So, And this is just a visual, again, of how the three types, the divisions, the special forces have to work together to provide optimal immunocompetency. This is a slide that sort of is a visual on the acquired antibody-mediated immunity. Adaptive immunity is immunity that a person's body learns to make. It's an adaptive response to invasions by organisms. It's an acquired immunity. It's active or passive, and it's acquired naturally or artificially. Active immunity occurs when antigens enter the body, and the body responds by actively making specific antibodies against the antigen. So it's sort of, as we talk about babies, how they're more susceptible to diseases, we keep them away from sick people when they're little. And that's because they have not had the time to acquire the immune response as older adults do. So that's just kind of an example of we sort of acquire it over time. We are exposed to things, and our body, as we are exposed to things, learns those foreign things, and it can kind of build up a really quick natural response to that to keep us from getting sick. Natural active immunity occurs when antigens enter the body and without human assistance, and the body responds by actively making antibodies against the antigens. It is the type of immunity that is the most effective and the longest acting. So it's our natural ability to recognize foreign objects and to make antibodies to fight against that. An example of that would be chickenpox virus. We have a vaccine against that now, but it used to be people would almost purposely expose their kids to the virus because what happens is once you get it, you don't get it again. Once you get it, your body makes up antibodies and you don't ever get it again. So that is an example of a natural active immunity. Artificial active immunity is sort of along the same lines. However, we are purposely vaccinating, so we are purposely giving ourselves small amounts of the antigens in order to build up those antibodies against it. So that's just why it's just artificial, because we are actually placing a small amount of the antigens into the person. And it's the same idea as a natural, but we are just artificially exposing the patient to the antigens. Passive immunity occurs when the antibodies against an antigen are in a person's body, but were transferred to the person's body after being made in the body of another person or animal. It provides only immediate short-term protection against the specific antigen. Natural passive immunity occurs when antibodies are passed from the mother to the fetus through the placenta. You've heard that breast milk is really great for newborn babies because it gives them a natural passive immunity against, they think that they're healthier because they get the antibodies that the mom already has. So these are just, you don't have to memorize all these, but just understand what acquiring antibody-mediated immunity is about, as opposed to like cell-mediated, which we're going to talk about. Okay, cell-mediated immunity, I'm going to call it CMI. Cell-mediated immunity or cellular immunity involves the white blood cell actions and interactions. This type of immunity is provided by lymphocyte stem cells that mature into secondary lymphoid tissue. These cells are known as the T lymphocytes. I like to call the cell-mediated immunity. It's the big guns. It's the boys that come in and really clean up the job and do the job, clean it up, really take care of business. The CMI regulates the activities of the AMI, the autoimmunity, and they also kind of regulate the inflammation. Like I said, they kind of clean things up. The inflammation has gone in, your acquired immunity has gone in, And now the cell-mediated guys are coming in to like really seal the deal. So they kind of regulate all this stuff. For total immunocompetence, the CMI must function optimally. So there's 4 T lymphocytes types, they're subsets that are critically important for the development of the CMI. The first one is the helper T cell. And then you have the suppressor T cell. And then there's a cytotoxic T cell. Sorry, this is terrible handwriting. And then you have the natural killer. The natural killer T cell. Big guns. They all have their special role here. The natural killer cells have a direct cytotoxic effect on some non-self cells that are independent of other white blood cells. The natural killer cells conduct and seek and destroy missions in the body to eliminate non-self cells. They are the most effective in destroying unhealthy or abnormal self cells, such as cancer cells and virally infected body cells. One thing to note, I want to make a little comment about the helper T cells. The helper T cells are also known as CD4. They're also a CD4 cell. And what their job is to recognize self cells versus non-self cells. And they secrete a cytokine that can enhance the activity of other white blood cells. So that's why they're called helper, because they can enhance the activity of other white blood cells. And the reason that we note this is the fact that the HIV virus, likes the CD4 cell. It can attack it, and it can kill it and take it over. So just keep that in the back of your mind, that this is the cell, the white blood cell, the part of our immune system that HIV attacks. And you can see how that would be detrimental. These are the part of the big team. These are part of the big guys, the CD4 helper cells. They're part of the big team. So if they are taken over by a virus, then it compromises our immune system significantly. That's why that's a significant piece of information to know. Okay, so also for Module 2, we talk about allergies and hypersensitivities. This is in Chapter 2 of IGE. So an allergy is just basically when somebody responds to something, your body kind of identifies it as an antigen or a nuisance, and it sort of triggers that inflammatory response. Examples of that is like a peanut allergy. Most of us, when we are exposed to the oils from peanuts, your body's like, oh, that's a peanut, and that's cool. Some people, they identify the oils from a peanut as foreign. So the body kicks in an inflammatory response. It's that immediate response. It could be just the inflammation in the nares and the eyes, on the skin, that's triggered. So they start to break out. They might get a runny nose, itchy eyes. That is an inflammatory response that's related to an allergy. It's an abnormal response. Anaphylaxis is kind of taking that allergic response to the next level. It's like an allergic response on steroids. It's when your body reacts so violently to exposure to something that, like, your throat swells, your face swells, eyes swell, everything. This inflammatory response just goes insane. So that's an emergency situation, and that's like a very, very severe allergic reaction. So just make sure you have an understanding of the difference between these two. It's important to understand, if you kind of go back to the sequence of the inflammatory response, there are stages: stage 1, stage 2, stage 3 of inflammation. In stage 1, once the body recognizes something foreign, it is that initial inflammatory response. It's a vascular part, and that's when the blood vessels kind of dilate and leukocytes kind of come into this area, and the leukocytes secrete histamine, serotonin, and kinins that constrict the small vessels and then dilate the arteries to get blood flow to this area. That's what causes the redness and warmth and that increased blood flow. So that occurs in an allergic reaction as well. And that's why you see all this swelling and redness and craziness. And that's stage 1 of the inflammatory response. And the reason I mention that is that histamine response, that histamine release from the leukocytes, because a treatment for allergies frequently is something that we call antihistamines, and you've probably heard this, you've probably taken them before. So basically it blocks that histamine release, so it decreases the amount of redness, swelling, and so forth. It decreases that response a little bit. If you want to review that inflammatory response, that sequence of inflammatory response, it's on page 308 in IGGI, and that's in chapter 19. There's about a half a page or so that kind of reviews that response. Okay, in this slide, we're just going to kind of go over what is referred to as a hypersensitivity or allergy. And this is related to the immune system and the fact that it is actually an excessive inflammation occurring as an excessive response of the immune system to an antigen, to the presence of an antigen. Typically, these antigens are identified as something that are abnormal or not welcome, possibly, to that specific person. And it's usually things that are typically okay for the human body, but for whatever reason, some individuals have an exaggerated response to something. A good example of that is peanuts. The majority of people can eat a peanut, be near a peanut, and be just fine. But as you know, there are some people who have a terrible, exaggerated, excessive inflammatory response to the presence of a peanut, of a tree nut, or something like that. And so it's just that excessive response of that immune system that for whatever reason recognizes that peanut as an antigen, and it produces an immune response that is excessive, with excessive inflammation. So that is that inflammatory response that causes the swelling, inappropriate swelling, like the swelling of the tongue, swelling of the eyes, swelling of the face, causes it to swell, make their airway swell, which causes a compromised airway. Now that's a pretty excessive inflammatory response. There are different variations of it. These are listed in your IGGI book. There's different types of allergic responses or hypersensitivities, so we'll talk about those briefly. One thing I do want to mention is that this chapter is actually incorrect in your 8th edition of IGGI. The 8th edition of IGGI, this is all in chapter 20 for you in your IGGI book to review. There's the different types of your hypersensitivities. Make sure you kind of review those because, like I said, some of them are life-threatening and some of them are not. For instance, type 1 is basically it's reaction of the IgE antibody on mast cells with antigen, which results in the release of mediators, especially histamine. So histamine, typically we've heard of taking an antihistamine for something like an allergic rhinitis, hay fever, anaphylaxis. So these are immediate, type 1 is an immediate hypersensitivity in response to being exposed to something. It could be just something as much as like hay fever or allergic rhinitis where you get like that inflammation in your nose and you get stuff and you start sneezing and things like that. Or it could be like an allergic asthma where the airway is very much compromised because of the response to the antigen. The release of histamine is part of the inflammatory response, and that is why an antihistamine, such as Benadryl, or also known as diphenhydramine, which is the generic name of Benadryl, that's an antihistamine that can be utilized to decrease the hypersensitivity. Type 2 is a cytotoxic hypersensitivity or allergy. By the way, hypersensitivity and allergy are usually used interchangeably. Cytotoxic, the type 2 is typically like your autoimmune stuff. Myasthenia gravis is one of them. Type 3 is also one kind of that autoimmune disorders that we'll talk about. Type 3 is immune complex mediated. It causes things like vasculitis. Lupus is something that is a type 3 hypersensitivity. And then type 4 is a delayed response. This is always kind of fascinating to me, the delayed response. It's kind of a sensitized T cells with antigen and release of lymphokines, which activates macrophages and induces inflammation. But this is the delayed. So it's basically you're exposed to it, and then a little bit later, you might have a little bit of response to it. Poison ivy is a good example of that. And TB tests that you guys have had. So you know how you have to wait like 48 hours before they read it? That's because it's a delayed response that you would have. You don't have to necessarily memorize these, but just understand that there are definitely varying degrees of hypersensitivity and allergies. And know that a delayed one would not be as an emergent situation as possibly the immediate, which is type 1. So read through these in your chapter 20. One of the things that I always want to point out to people is the best way to not have an allergic reaction is avoidance. If we've been able to identify the specific allergen that causes the reaction, then the best way to keep it from happening is to avoid it. Now, there are some things we cannot avoid. If you're allergic to just pollen and things in the atmosphere, it's very difficult to avoid that. So, you would have to take medication such as antihistamines to prevent that kind of a reaction from occurring. But if it's something such as peanuts or a medication perhaps that you're allergic to, just avoid it. Don't take it. That's the best way to not have this occur. Treatments for hypersensitivity or allergies usually consist of antihistamines, which block that histamine release that causes the inflammatory response. Corticosteroids decrease inflammation. That's how they work. So they're used effectively for a lot of inflammatory disease processes. So the thing of it is it does decrease your immune response. So when somebody's on a steroid, they do need to know that it does make them at risk for getting infections if they're around sick people. And the reason that is how they work is they decrease that inflammatory response. So it can make them at risk for getting other things. But it does decrease that response, that hypersensitive response. So that's how it works for allergies. Mast cell stabilizers are, they prevent mast cell membranes from opening when an allergen binds to the IgE, which is the antigen. So they usually are kind of a preventive, usually a maintenance drug. Singulair is a mast cell stabilizing drug that is used quite often for asthmatics and people who have like an environmental trigger for their asthma. Anaphylaxis is that serious immediate reaction. It's a type 1 reaction where it's a life-threatening situation. Anaphylaxis is an emergency situation that needs to be identified quickly and treated quickly before a patient becomes extremely ill. It's the most life-threatening type 1 hypersensitivity reaction. It's usually a systemic reaction that occurs rapidly. It can affect many organs. The one that we are most worried about is sometimes it causes inflammations in those airways, and it can cause a patient to lose the ability to move air and get oxygen. So it's important to know if somebody has a history of any kind of reaction like this, a type 1 reaction. Maybe it's a peanut allergy that causes a type 1 reaction. Maybe it's a bee allergy. They need to, any of these people that have such an allergy need to be educated that they need an epinephrine pen handy. Epinephrine is the emergency drug to treat an anaphylactic reaction. There is some information in your book about how to take care of an EpiPen and how to educate a patient regarding the use of their EpiPen. So make sure you refer to that. Epinephrine is a drug that can help with that emergency situation. It increases blood flow to the area. And is the emergent drug that is required for a patient who has an anaphylactic reaction. So just to understand how this works, epinephrine would be your emergency drug when somebody's in really, really big trouble. They're losing their airway, they have stridor, they have bronchospasms, they're wheezing really bad. So we might give them a dose of epinephrine, and then to follow up, we might give them a dose of diphenhydramine to keep them, to decrease the inflammation with that antihistamine effect of the diphenhydramine. It's just a visual picture of the things that occur during anaphylaxis. It's an allergic reaction that involves two or more body system. Hives and difficulty breathing are typically big signs that somebody is having an anaphylactic reaction. There's a couple of pictures that you can see in your book of somebody that has angioedema of the face, lips, and mouth, and essentially what that means is it's facial swelling. And if you can imagine, any of that swelling around the face, mouth, things like that can lead to a loss of an airway, which can be an emergent situation. You hear people wheezing, decreased breath sounds. Those are signs that somebody is losing their airway and are in big trouble. And you need to get that epinephrine in and follow up with some diphenhydramine. Also think about if you have somebody who's wheezing, swelling, looking in trouble, call that rapid response team. If you suspect anaphylaxis, you got to get some help there so you all can kind of be sets of eyes to treat that patient immediately and make sure they get what they need as soon as possible. It's an emergency situation. Basically, if you are called into a room and they think they're having a reaction, you need to assess that airway first. So how bad is this affecting their airway? Are they already wheezing? Are they already struggling to breathe? Are their SATs already dropping? Or do you come in and they feel like a scratchy throat? My throat's kind of scratchy. I feel kind of weird. Kind of assess that airway, and that kind of determines what your next move is. If they're already wheezing and already dropping their SATs and already having trouble breathing, you are getting that epi right now. One thing to look at also in your book is that emergency care of a patient with anaphylaxis. Review that. That is exceptionally important. It's a QSIN thing as the quality safety measures, safety of your patient. So make sure you review that because it's a really good resource to determine the sequence of events and emergency care of a patient with anaphylaxis. And again, just want to kind of put up here, epi is your emergency drug. Epinephrine can be given IM or IV. It constricts the blood vessels, improves cardiac contraction, and dilates the bronchioles. That's the big piece that we need. It dilates those bronchial airways to get some air into that patient. So it works here. You do have some tables in your book that goes over the drug therapy for a patient with anaphylaxis. A good idea to look those over. Always look over those nursing safety priority boxes as well in your book because that points out big things that you need to know as a nurse about a patient with these disorders. Just real quick, want to go over latex allergy. Just want to make sure you understand that there are two types of latex allergies. Just as there can be for like anything else, you can have a type 1 hypersensitivity, which would be life-threatening. And when the allergen enters the body through inhalation or direct contact, it can cause a type 1 reaction. Some people may have a type 4 hypersensitivity, which is that where it just causes like a contact dermatitis. It's more like a delayed response. So some people might, if they get in contact with it, they might get a little rash, contact dermatitis. Some people might have both. They have a mixed allergic response to latex. They could have a little bit of respiratory issues as well as the contact dermatitis. The reason we need to know this in the medical field, and the really interesting thing that has kind of come about in the last 5 years or so, is they've been able to find out that there is a known correlation between people who have food allergies with people who have latex allergies. So if you look at somebody who has, I have some foods listed here that have some of these food allergies, and this tells you how many percent that they might have. Like 11% of people who are allergic to avocado, chestnut, or fig may have also a latex allergy. Kiwi, banana, and peaches are big ones. If they are allergic to these, they have a 35% risk of having a latex allergy as well. Just really kind of interesting. So if you look at somebody, if you have somebody in clinical practice that has these food allergies, you might go ahead and put them in latex precautions so that they don't use any latex. Healthcare workers, we don't use latex gloves or anything like that anymore. The only thing that I'm aware of that could be latex anymore is Foley catheters. The silicone Foley catheters most facilities don't think they work as well, so they do use latex Foley catheters. So if you have a patient with a latex or a food allergy, such as these fruit allergies, you would have to call down and ask for the silicone ones. So just in conclusion, really, about allergies and hypersensitivities, one thing that is really important that we ask of our patients is, do you have an allergy? Yes, I'm allergic to peanuts. Tell me about your reaction to peanuts. Oh, I just get a rash. Okay. Or if somebody tells you, I'm allergic to peanuts and I almost died from it, it's a little bit different precautions. We are going to do everything we can to make sure they're not exposed to peanuts. If it just gives them a rash, then we'll still be careful, but it's not as life-threatening. Same thing with latex. If they say, I'm allergic to latex, tell me what kind of response you have to it. Well, I almost died. Okay, that's serious. That's a big deal. Or I just get a rash on my hands if I get exposed to it. You need to kind of know the response that they have in order just to kind of direct your care and be on the lookout for things. So in summary, it's always a good idea to review with patients their allergies. So even if allergies are already listed, if you have electronic medical record and the allergies are listed, it's always good to review that with them specifically. Again, ask them, you're only allergic to Bactrim and salt. Is that correct? Correct. Are you allergic to anything else? The other thing that you really need to do as a nurse is to make sure you update it. So if they have some kind of reaction while they're in your care, you want to make sure you add that to their allergy list. And always make sure you refer to that allergy list to make sure we're not exposing them to anything that they might have a reaction to. A couple of other drugs that we use for anaphylaxis or hypersensitivity allergies. Definitely a diphenhydramine or Benadryl is a medication that we will use now. That is a drug that we will use as a pre-medicating. If we're worried that they might have a hypersensitivity to something, we will pre-medicate them, or we'll use it as a kind of a preventive thing. And that's a histamine blocker. It does do some work in that way, that it blocks that histamine. The thing that you need to understand about diphenhydramine is the fact that it will cause drowsiness. So they don't want to take it while they're getting ready to go to work or drive or something like that. Diphenhydramine would be something that they could take if they are going to be staying at home or getting ready to go to bed. Other medications are corticosteroids. You might know that as prednisone or Solucortef. But they're steroids, and basically they're anti-inflammatory. So they work in the way of decreasing that inflammatory response. There is some side effects of steroids or prednisone. They do cause some high blood pressure. They can cause some GI upset. And they can kind of have effects on your adrenal glands, which is part of your endocrine system. So they use this cautiously. They try to use them short term. Another very, very important piece of prednisone or the corticosteroids is that they typically taper them off. You can't just stop corticosteroids cold turkey. You need to be tapered off of them, and that's because of the adrenal response of the corticoid therapy. There is a good chart on page 390, chart 22.4, that talks about drug therapy. And it talks about the anaphylaxis, and that's epinephrine. And like I said, epinephrine is your number one drug of choice for an emergency. And then you kind of have your second line drugs, which is your diphenhydramine and your corticosteroids. And that concludes this presentation for Module 2, the immune system. This concludes the discussion for Module 2, the immune response. I look forward to discussing this more in class with you.